Hey folks, I'm Dan Dworkis, and this is the Emergency Mind podcast, a space where we bring together lessons from the emergency department and beyond about performing at our best when it matters the most and applying knowledge under pressure. I am thrilled to have my guest on the show today. This is Patrick Schouwenberg. Patrick is a surgeon intensivist with an incredibly rich and diverse background, currently operating in critical care air transport teams and super active in pushing the edge of both doing and training, what it means to do elite human performance in medicine. He trained initially at the University of Leiden in the Netherlands, and then as a surgeon in Germany. He worked in, let's see if I can get this list right. Patrick, you gave me quite the challenge here. All right, pre-hospital care, emergency departments, ward and surgery, intensive care environments, with fellowships in both trauma surgery and intensive care. And most recently, he's become the course director of an innovative education program focused on sustainable performance for doctors and nurses. Patrick, man, like such a cool bio. So excited to get into this. And most importantly, thank you for coming on the podcast. Thanks for being here.
Thanks so much, Dan. Calling in from the Netherlands. So good day.
Absolutely. I've been really excited about this. Patrick and I had some great conversations at the Mission Critical Team Institute's UK summit and then on and around since then. And I think there's just a lot to dig into here about human performance in various different environments, but also in general about performance in medicine and how do we think about it. I guess for folks that don't know you, Patrick, what did I miss in that bio? What do you want to do to introduce yourself to the people listening here?
Well, that's about it. I became a surgeon in Germany and then fell in love with critical care medicine because it's so complex and it's challenging. And from that, I came back to the Netherlands, became a critical care physician, and noticed that in this sometimes moments of uncertainty, when I would thrive, I would see my colleagues sometimes freeze. And I was really wondering about that how do some people perform under pressure and others don't? What is that? And in critical care, when we get our fellows, they already trained for about 6 years. So they are pretty proficient in their job. They might be cardiologists or anesthesiologists. And still, when there's performance, when there's a resuscitation, not everyone would perform equally. And I was just fascinated by that. How can you analyze or train that? And then I delved into that. And it's just a fascinating where we've begun adding so much gadgets in treating our patients, but we haven't really changed the way that we train our doctors and our nurses. So I really delved into performance psychology
Hmm.
and why people thrive under pressure and some people freeze under pressure. So because I had so much experience as a pre-hospital doctor or in the trauma bay with people like yourself and other colleagues from critical care physicians,
Mhm.
they didn't have that background and somehow they were missing these experiences. And I wanted to bring to them a program to teach them to perform under pressure. And by doing so, I learned a lot for myself, vocabulary and recognizing stuff. But I found it really important because some really good doctors would almost quit their jobs because they were feeling so much pressure and they would
Hmm.
never really recover from that pressure. So that was my goal and what
Mhm.
drives me to share that with my colleagues. And I'm
Hmm.
mostly doing that now for my critical care colleagues in the Netherlands. And I see that they really grow with that. And it's something that we're still missing from our curriculum.
Yeah, thank you. Thank you for that. So I'm curious, we ask this question a lot within the context of the podcast and the project in general, but do you think that the ability to perform under pressure is a character trait? Is it a learnable, teachable skill? Is it based on exposure to things? Where does that come from? Because this idea of person to person variability, I think, is quite, you see that whether as an operator or somebody who's teaching, you put a bunch of people in the same circumstances and they behave differently. So imagine for a moment that our job was to model that somehow. I don't think that's our job, but let's just pretend that is for a minute, right?
Yeah.
What do we put as the big chunks of that model? What goes into that?
Yeah. So for myself, I think I learned the hard way just by falling and getting up and having so much exposure or time on target. From falling and getting up, I learned a lot. But I think that we can teach people without falling, guide them. So even if you're not a star by yourself, I think we can teach them, giving them tools and skills to perform under pressure. So you don't have to bring it from a young age. I don't think that you need to be time on target all over again. I think you can teach people skills. And for example, when they divert from their path or when they feel that they are anxious, we give them tools to fall back onto. Like in trauma surgery, we had the ABCD. So when stuff gets really hard, you fall back into your basics, your ABCD, airway, breathing, circulation. So we give them those skills for people who don't have the advantage like I did from surgery, so much time on target. We have colleagues from internal medicine or cardiology that have a different background, that are not so proficient in the trauma bay, but they still need to lead resuscitations or when a person crashes in the critical care unit,
Mhm.
and then all of a sudden it gets dynamic really quickly. So I think we can teach them tools.
So there's a sense here of the importance of exposure, right? Being in the situations where you are called upon to make these decisions and lead these teams. And that's getting at that time on target idea. There's
Mm-hmm.
also a concept that you're bringing out, which is the efficiency of that time, right? How much of that time are you converting into learning? And there's a sense that we can adjust that that coefficient, as it were, right, such that the time you spend is spent better and more
Mm-hmm.
efficient and brings you towards a sense of mastery faster. And I would also add not just faster, but with less collateral damage, probably, both to you and to the people that you're taking care of. So let's press on that. What does that look like? What is it that changes the efficiency of learning from an encounter?
So I think that from one encounter you can make it like three encounters. So you triple your exposure. First you have your real-time exposure, you have your resuscitation, it went well or didn't went well. And then we always do an after action review. So that's the first time that we start to dissect what happened, and not from just one perspective, but from everyone in the room. And we choose a subject within the resuscitation to delve upon and dissect. And so that's the second time that you're experiencing the event and experiencing it from different perspectives. And then the third time is kind of when you are going back to your daily routines and or maybe going home on your bicycle in the Netherlands, when you start just thinking about, okay, what happened and how I would do it the next time, get better 1%, for example. So you have your event, your after action review, and just ruminating on what happened on your drive home, for example. So then you triple your experience with just one exposure.
And how active are, okay, us go back in time a little bit, right? Because I'm gonna take us backward and then I'm gonna take us forward again to where we are now and ask some questions about how you're operationalizing some of these ideas. But I'm really curious, as somebody who has seen medicine through so many different lenses, right? The lens of surgery, the lens of critical care, the lens of emergency. How did these different groups think differently about these ideas, or to what extent do they? Because I think we're all building our own local solutions to some of these ideas because we have to, right? You have to train, you have to increase the efficiency of your training in order to take care of patients. But that doesn't mean that we're all looking at it the same way, and it doesn't mean that we're actually harnessing knowledge collectively. So what have you found that are the differences between those different views of the world, let's call it?
When I was in surgery, I was trained in Germany. It was really top down, maybe master and apprentice. And that was the way that the world was. The professor told us what the world was like, and we copied it from him. So there was not so much critical thinking of the apprentices, and more, this is how I want you to see the world. This is the reality. When I came to the Netherlands, because it's a smaller country, we adopt from outside, from Scandinavia, from the United States. We're very flexible and we're educational driven. So it's much more on an equal level. So not master apprentice, but more mentorship, allyship. And then we take the knowledge from the fellows that have also trained for 6 years and we incorporate them in what the world looks like. And my worldview might be not the one that they have. So it's much more of a conversation instead of a top-down monologue. And I think that's what we need now. So not just telling people how to work, but taking from their experiences. When we have cardiologists or people from anesthesiology, they can teach us, the staff, about what the world looks like. So it's more of a conversation instead of information downwards.
That's quite interesting the way that the system there works, where folks have had years of experience in a specialty before they then go back and become a fellow, right? I think
Yeah.
we see that very differently in the States, where you go through residency training, which might be as little as 3 years, or perhaps as more like 7, depending on what you're doing. But then you're immediately the fellow the next day. And there's this real step function jump between June and then July 1st, where all of a sudden you're the fellow. And it's a little more complicated to think through what that could look like in other systems. I love the fact that there's a conscious effort to harness the ability of these people, of the people that are coming through your program, to use the skills and resources they already have. I think that's really important. How logistically do you do that? Are there times when they are giving the lectures to you or back and forth? Or is it more sort of ad hoc? Hey, this patient is here for really complicated heart failure. Oh, you're a cardiologist. What do you think about this? Like on the fly.
Yeah, it's very dynamic. So we have, with my teaching program, I use the fellows and the residents. I just hand them topics and I say, explore this topic, and then you become proficient in this topic and teach us about it. But also with bedside teaching, when I have a cardiologist, I just let them do their thing and let them shine for a minute and teach them something to the colleague from internal medicine. And when we have patients who've been on the ICU for days and they have complicated problems, we do use these fellows and we give them the responsibility of, what would you do? You are in charge now. Explain with your knowledge, what would you do? And in our ward, medically, we are in charge, but there is no hierarchy. We have the residents and the fellows treat the patients and we supervise them, but they can make decisions about treatment. They talk to other specialties from surgery to neurology, and then they give us feedback on what they would want to do. So it's almost like we have them for 2 years before they become a critical care physician. It's a learning conversation. We just
Mm,
guide them and nudge them into the right direction, not having them make mistakes, but earning up to their choices and make them accountable. So instead of telling them to do the paperwork, discharge the patient, do all the stupid stuff, get the coffee for the staff, there's no hierarchy. And I think that gives them the security
mm,
to take the chances, and they know that we are there as a safety net. And then the first day of the 2 years, the safety net is really close. And then the last day, the
sure.
safety net is almost gone. And the interesting thing is that when you're in your fellowship in the last cycle, you start teaching the people who are just coming in. So you remember how it was for you when you just came in and everything was big and scary, and you've seen your own growth. You recognize yourself in the new generation. And we, as staff, we try to stay back or be a fly on the wall, just see that there's no mistakes, and we'll have them explore critical care. So
Mm.
it's just nudging them in the right direction, showing them what right feels like if it's difficult to explain something. But we give them their learning experiences.
Okay, so we've put one flag down, which is the idea of increasing the efficiency of learning from a particular encounter. And now we've put another marker in the ground, which is the idea of what kind of system are you going to wrap around the trainers and the trainees such that it's more of a conversation and a joint exploration than it is a hierarchical teaching. I want to put a third down, which is something that you and I spoke about back in the UK and something that's been floating around in the back of my head since then, which has to do with the dyad, the interaction between the teacher and the student, or the more senior and the less senior. And we discussed a couple of ways that can be. And so I'm going to throw these words out here, right? So mentor, ally, and enabler. And I'm wondering if that sparks anything for you, if you want to take that and run with it. What does that system look like?
Yeah, so there's always some seniority, and this would be mentorship. So I'm guiding my pupils, as I said, showing them what it feels like, because sometimes it's really difficult to put into words when a patient is deteriorating and a novice might not really just see it. And I'm guiding them to just don't look at the monitor, look at the patient in the bed. Can you feel this? Can you smell this? What does it taste like? So that would be
Mhm.
a mentorship, just showing what right looks like. And then we have sponsorship. That would be opening doors for fellows that they couldn't open themselves, just to get rotations into cardiology or meeting interesting people to get exposure, for example, or presenting in on conferences. So we have this mentorship and sponsorship, opening doors. And allyship would be just being inclusive, having so many different cognitive diversity. Just like in surgery, all the surgeons looked alike, they talked the same, and they were just some sort of a character imitating the professor. In critical care, we try to be as diverse as possible,
Mm.
from cultural backgrounds, immigration, sexual preferences. It really doesn't matter. So in this allyship, we just try to have, and it's not even a melting pot, because we want you to keep your identity, and this identity adds to the collective.
Mm.
So in these three things, mentorship, sponsorship, and allyship, we can really find a way to teach our students.
And how explicitly are you making this sort of pattern of stuff when you're bringing folks in? If I'm your new critical care fellow and you're sitting me down the first day, are you going to talk about this? Or are you going to say, hey, here's a couple of different ways you're going to see this relationship work?
Yeah, because it's not usual in the Dutch system. We're still exploring, and they might think that there will be a top down, and they might think that they'll just do discharge papers. So
Mhm.
we're setting the scene by introducing these things. And for a lot of colleagues, it is somewhat new. And then you create an atmosphere, and I'm very explicit in it and intentional in this. So I introduce these concepts, and they are mostly new for colleagues from the previous generation. Nowadays, it's getting more normal, but we have to be intentional about it. And also for myself, for some colleagues, I'm using more of the mentorship, for others, more of the
Mm.
sponsorship, but I'm really explicit in this is the way that I'd like to work. This is how I see our relationship, how we work together. Yeah.
It's interesting that you mentioned that is relatively unusual for the Dutch system. How has the system responded to you bringing in these sort of new or different ideas? Is there a sense that, hey, this is great, or is there a sense of, oh, this is Patrick off on a crusade again?
It depends on who you're asking, of course. So the feedback that I'm giving is that the residents and the fellows are really recognizing this dynamic, and they really feel protected by it. They feel like it's a
Mm.
safe place to work from. And it's not that I'm protecting them, we really let them fall on their face. Sometimes when you're talking to the senior staff who've been doing their job for 20, 30 years, it's sometimes difficult because it takes energy changing the system.
Mhm.
So I'm not forcing it on them. I'm just showing them the results, or how the fellows and the residents are reacting to the way that I'm working with them. And then it trickles down a little bit, or it trickles up to the senior. But there's also people who just want to do it their way. And if you're in a large group, like a university hospital, then it won't reach everyone. But I think that I have my circle of influence. And if I influence my students and my fellows, they will bring this to their generation. And then
Mhm.
in a year, in 2 years, in 10 years, we've reached a lot of people. So I just keep adding people to it, and they'll bring it to their colleagues, and then we'll get a movement.
Yeah, I think one of the challenges in medicine when there are so many different people who take on a leadership role shift to shift, and when there's not the continuity of command of a unit or a group, right? It's okay, it's Thursday, so Patrick's in charge, and then it's Friday, and then Dan's in charge, and we're going to do it Dan's way. So you get this thing we've called before yo culture, where it goes one way and then goes another. And well, Patrick really likes mentorship and allyship and sponsorship, and Dan wants you to get him coffee, which is not true, by the way, but nevertheless, right? You have this back and forth pull to it. Whenever you are working with the next generation and arming them with new ideas, right? Part of your job has to be how do you deal with that yo culture on the days when you're not there? So what are you teaching folks around that? Because I love this arc of, yeah, in X number of years, I will have reached a critical mass and then everybody will be doing it my way. I think that's amazing. But in the meantime, we're stuck with this sort of back and forth thing. What do you do with that? How do you train folks for that?
when we have our lectures or education, when we are teaching the students, we also have the permanent staff on board. So we have groups of 40 people. And then we talk about resilience, we talk about performance under pressure. So they get exposed to it.
Hmm.
Some of them are early adopters, others are
Of
just
course.
leaning back a little bit. So I'm really not forcing it on anyone, but they do see that with minor adjustments, you can get really good results with the younger colleagues. They respond
Mhm.
really well to it. So I make the threshold really low. I'm not forcing anyone. And also this podcast is also bringing it out,
Mm.
showing that we are working, you and I are working on this performance concept. And other people who are thinking about this or doing it just by themselves, they feel like-minded people.
Mhm.
So it will maybe spark their energy to make the next step. As you said, how do I influence other people? I try to nudge them in the right direction, showing them it's not scary, it's not difficult,
Right.
it's just a new way of thinking, and you'll probably be more efficient in the long way. We're making better, balanced doctors who are resilient instead of just photocopies of the old professor. Times are changing, our patients are changing, the healthcare system is changing, so we need to change as well. And all change takes extra effort and energy. But then you shouldn't be a doctor if you think, I graduated, I know everything now, and that's it. I'll be just doing the same thing for 30 years. So people notice that with little effort, you get really large results in the long way.
Yeah, I love this concept that our goal is not to create photocopies of our predecessors, but rather to create a new and evolving system that thinks around the corner and adapts to what's coming next. I think that's critically important. And
Mm,
when we leave medicine for a moment and look more broadly at the world that we inhabit in the Mission Critical Team Institute, like we certainly see that cross cutting across fire and military and aerospace as well. Challenges are changing, the team structures are changing, the ways that people are interacting with the systems around them are changing. And that requires a different set of skill sets, adaptability, and flexibility more than anything that we need to start training into the folks coming up behind us. So, huge applause for you all for leading the wave of that in so many ways. And actually, maybe this is a good time to pivot into this. I'd love to hear about, you were telling me about one of the wins that you all have had, which is changing the culture around handovers to include more of a storytelling aspect to it. Can you talk about that a little bit? Because I just thought that was so cool.
yeah. So I discovered storytelling a few years ago, and I found the concept difficult to grasp in the beginning, because we were trained in surgery and critical care to be efficient in the handover. In 120 seconds, you present the patient, what's the problem, what are we treating, and what's the plan for the next day, for example. And if you have 15 patients, it takes half an hour, and it needs to be efficient, but it's taking the soul out of it. And sometimes when a senior fellow does the handover in the morning for the day shift, you can see the younger students, they drift off in their mind because the abbreviations, they don't mean anything to them.
Mm.
They have no idea what the real plan is. So it's really almost, it's efficient, but it's clean and cold. So in the hospital that I'm working now, we have 3 separate ICUs, and there might be 30 patients, and every ICU has 15 patients or 10 patients. So you do your hand, and then you all converge in one room after half an hour, and all the ICUs, all the fellows, all the research PhDs, they come. And then we have the fellow who had the night shift present a maximum of 3 patients that they
Mm.
admitted to the ward. And then we say, don't do a handover. Tell the story of what happened. So they try to tell the story of what happened outside of the hospital, from the flight crew, for example, when they come by helicopter. Then they tell the story arc of what happened in the crash room and all the uncertainty they had and all the paths they were choosing and the diagnostics they were doing, the resuscitation. So it's making it really, you can see the students building the picture in their minds. And then we have a story arc of what happened to the patient, and they almost died, but then we saw this and something went, and this young doctor saw something that we didn't see, which made the patient better. So there's a whole story arc.
Mm.
And we have the feeling that if you present the patient and take much more time and just don't do the lab results or the CAT scans, but tell the story of what happened, how it felt, how the tension that you felt in your room, or the relief when the endotracheal tube went in because it was really hard resuscitation. And we feel that these stories, they stick with the younger doctors. And even if they haven't been with resuscitation, once they are going on the floor and they're doing resuscitations, they use this as almost as it was their own experience. So we take this very clean handover and make it into a story. And we don't train our fellows, we just let them
Mm.
tell the story. So it's always their own way of telling a story. Some are really good at it, others not, but it's okay. And if they want to tell a story that takes 5 or 10 minutes, so be it. If that's necessary, if they need lots of time, then it's always the way they want to do it. So we're stepping back from this very clean handover and giving them the freedom to tell what happened. And then they tell a story that took about 8 hours. So it has an arc and then a resolve at the end. And it really sticks with the younger colleagues
Mm.
because they somehow identify with it. It's like watching a TV series.
Yeah. That's amazing. I love that. Just tell the story of what happened with sort of the structure and space to do it. I'm curious, do folks tend to, 'cause you were highlighting how they might think about almost the meta story, right? What was going on in their heads, what was going on around them as they were doing the work or processing things. Was that a nudge from you all? Was it tell the story and include the inner monologue, or is that just a natural side effect of what's happened as
It
people have
is a
been doing
natural
this?
side effect. When I do handovers, I sometimes tell the story so people see how I tell stories. But the way they do it, it's really their own. And some of them, they are so good at building the scene that you close your eyes and you're in the living room of the patient who just collapsed and the helicopters landing outside and the leaves are flying off the trees and the police is trying to get everyone to stand back. And that's wonderful. And everyone has their own voice, but everyone has
Hmm.
their own interpretation of their storytelling. And if I'm forcing my way, it wouldn't work. So just let them do their thing.
So interesting. You're reminding me of a guest I had on the show a little ways back, Kevin Sear, who is the head of a SWAT unit. And one of the things when his juniors are presenting to him a plan, he will typically ask, okay, tell me what you thought about but didn't choose. Tell me what else you thought about and didn't choose. And to me, there's this resonance there between that idea and what you're describing when you're asking people to go through the exercise of painting the picture at various points of uncertainty, right? Here I was, and I was trying to figure out, is this more of heart failure? Is this COPD flare? Is this, what are we looking at and why, right? And what does that teach me? And here's how I decided to break that stalemate for it. I think that's really incredible to think through that idea of what did you not do? Why did you not do it as an exercise for it? Man, what a cool thing from that. How is you mentioned that the lived experience of the people listening was really positive. They were enjoying it, they were hearing it and taking that information. What's the lived experience been of the people telling the story? What does that seem to do for them?
I think that they feel that they are being seen and that their opinions are worth telling instead of just giving the information as it was very clinically. You can position yourself inside the story or as a bystander. Most of the time, the fellow is in charge and they present the story as it developed, how they made choices. So we let them we let them shine. We let them tell the story and the decisions that they made instead of just telling it very flat. So
Mhm.
if they made decisions that were life-saving or life-threatening, they own up to it. But then the person that's standing there gets all the attention that they deserve. I find it difficult to explain, but I want them to be seen as
Sure.
the doctors that they are instead of just one cog in a big system. So yeah, I think it gives them more self-confidence just standing there presenting to a big group, explaining the decisions that they made. It builds self-confidence.
Absolutely. and a sense of self, a sense of purpose, not just in their craft, but in who they are. I
Yeah.
want to highlight one thing that you all do that I think is super interesting. You mentioned that when they're doing the more standard handover, right, the 120-second handover, that a lot of the juniors are overwhelmed by details or they're overwhelmed by the acronyms or whatever it is. And I think this is a really common problem set that we're seeing across medicine and outside of medicine as well, which is that communication is a sender and a receiver problem. You have to be set up to receive in a certain way, and you have to think consciously about how you're sending it. And are you sending it in the way that the receiver is set up to receive it? We think about this on stateside when we learn radio etiquette, right? Why do you answer radio in a certain way when there's a call in from an ambulance or something? It's because you're minimizing friction of communication and allowing information transfer to happen efficiently. One of the ways that becomes important, that receiving information and that sending information becomes important, is that you put the markers around it. You put the structure around it. So when you and I are sitting down, we need to agree first what kind of conversation we're having, right? Are we going to have a 120-second efficient passive information doctor to doctor? Or are we going to sit down and tell a story? And we're going to tell a story, and it might not be obvious at the beginning why we're telling this story, but it's going to get somewhere. And that somewhere is either a question or a point or a thing that I'm chewing on or something that keeps me up at night or whatever it is. But being clear about which one we're doing is really important. So that might sound obvious, but I love the fact that you all go into a different room to tell the story. I don't know if you did that on purpose or not, but that's a ritual, right? You're crossing a threshold. You're going from some place to another, and you're saying, in this room, we're going to tell the story. Over here, you need to have your antenna tuned like this, and here's what you're going to receive. But over here, we're going to do it differently. I just think that's wonderful.
So it wasn't a choice. It was just the way we did the handovers
Mm.
historically. But it does help going to a different room, sitting down, and this room is for storytelling. And I think some colleagues don't even notice it that we're telling a story. They still feel like getting a handover, but they're treated to a story. And some of them really notice it. And others just feel that it's a very large handover because it's something that took 8 hours. Yeah. And the other thing about sending and receiving is that there was some research done of people doing handovers and then judging themselves on how efficient they were. And some of them said 100% efficient. And then they asked the receivers and they said not 100% and maybe 80% or 60%. And then now we always do a sort of a callback. So I'm
Mhm.
sending you information about the patient. And I think I've sent everything perfectly because otherwise I wouldn't do it that way. And then when I get the information back, I think it landed completely different. And the picture that I wanted to paint is not the thing that they received. So we always try to have them tell the story back during the small handover. So if I understand correctly, the patient has this, we're looking for that, and we're doing this. Is that correct? And then sometimes I need to fill in the gaps because that what I sent wasn't what was received, for example.
Yeah, I think if you want a really very topical example of that, just podcasting. You and I are having this conversation right now, and I don't know. I think we think it's going well. Hopefully it is. We have no idea how people are receiving it when they're out there in the world thinking about it. And it's an interesting challenge of this, which is that you don't have that other end of the closed loop when you're communicating and really honestly storytelling in this format, right? You're sending it out into space and hoping that it lands somewhere with people and plants a seed and then causes more conversations to happen. But I think you're right when we're working at teams that interface under pressure, and specifically when we're transitioning from team to team, that's a really important structural space to be careful of to make sure that we're having that conversation in there. My suspicion is that the more cognitive diversity we bring into teams, the richer and also more challenging that particular skill set is going to be, right? We're going to have to do more pre and post conversation work to make sure that we're actually communicating around the same issues versus the older way of photocopying the professor. When everybody learns to teach and speak and work in the same way, it's a little bit easier. It's short term more efficient because for relatively stable problem sets, you're able to achieve a higher degree of rapidity and force of action in there. But for changing problem sets, for complicated systems, for rapidly adaptive problems, you're quite limited in the amount of and the flavors of output you can produce. We think about this a lot in mission critical world as well, the increased ability of cognitively diverse teams to operate across problem sets, but also the challenge at the beginning of getting them to operate together. This idea of the callback, like the pre and post conversation, I think is a really interesting one that we can keep exploring as well.
Yeah, I agree totally.
Great, because I didn't have a question for you there. So we're that was our post conversation relatively quickly. Patrick, what else are you all working on? So you've been exploring storytelling, you've been thinking about increasing the efficiency of learning, about changing the relationships between teacher and student in your intensive care units. What have we not talked about? What else are you all digging into?
Yeah, so when I came into the hospital that I'm working now, I got the freedom to develop a program for talking about performance and resilience. So for 1 month, all the teaching, besides bedside teaching, all the teaching would be on resilience
Hmm.
and performance. Because I noticed that we train them of all the information and the protocols, but not how it feels to perform under pressure. And so many doctors don't even have a vocabulary talking about what it feels like, the pressure that they sense, or so my goal was just to expose them to the vocabulary. So at the end of the month, at least we could talk about
Hmm.
resilience and performance. And so I had a pilot program for the doctors in ICU where I twice a week would have half an hour giving a lecture. It was still interactive, but there were also like 5 moments of 15 minutes, like almost like a TED talk, where I'd give a subject to one of the
Hmm.
fellows or residents and I'd say, explore this. This is about heart rate variability. This is about sleep. This is about artificial intelligence and cognitive offloading. And they would just explore this and try to hand it down in 15 minutes. Because the problem is that all the students and even staff, we have different schedules. So I wouldn't have them from A to Z. Some of them would hear one lecture and miss the next one.
Hmm.
So
Sure.
it was really difficult to have this thread going through. And at the end, we ended with an intervision talking about what drives us, what are the challenges and the problems. And I would just have them explore everything. And at the end of the month, you noticed that they were using vocabulary that they didn't know
Hmm.
before. So they could talk about the things that they were feeling, but never really would express. And they would notice that they were having challenges that they thought they were only struggling with themselves. And then the older fellow said, I recognize this. And
Hmm.
this was my solution. So I was just facilitating this conversation at the end of the month. And it was really nice. I think I really gave them something to explore. And I think that's something that we're still missing in our educational system. What does it feel like to perform, and what are the challenges, and why does it sometimes feel very hard when you lose a patient, and what can you still learn from that? So that's what I did for a
Yeah.
month, talk about resilience and performance.
That's incredible. I wish I had that when I was coming up for sure. I think you're right. We teach a lot and train a lot around the what and the how, but we're missing a lot of the inner lived experience and what that's like. It's very encouraging to see efforts like this springing up at very that are trying to tackle this head on. I hope that there are folks listening to this in various places who are like, well, yeah, obviously they would do that. That would be incredible. It'd be incredible if this was so obvious as to not be interesting. But I don't think that's where we are yet. I think we're
Yeah.
still at the pilot stage in a lot of ways across disciplines. And thank you for the work you're doing on that.
As you said, it was something that we were missing during
Mhm.
our rising to the top. And it might have been that some of our colleagues that did make it would have been the best colleagues
Yeah.
if they had just had these tools and skills that we are trying to hand down. Yeah,
Yeah.
it used to be just keep on faster with more intensity and don't talk about your feelings. And then that's the coping strategy we had in the old days.
In
Yeah.
large quotes for coping strategy. Yeah,
Yeah,
exactly.
yeah,
Right.
yeah, yeah,
For sure. Patrick, I want to give you the chance to issue a challenge to folks listening to this, something you want them to do differently or change on their next shift or in their next rotation. And while I'm giving you a second to think about that, I'll throw our disclaimer in here, which is that everything we do in the Emergency Mind podcast is about thinking about the best of what other folks already know about performing under pressure. None of it is medical advice. And myself or my guests, our views are our own, just our own, and not that of any institution or group that we work with. That way they can keep coming back and not get in trouble. So, all that said, Patrick, what do you want to challenge folks with?
Yeah, what to do on Monday. So I have a twofold challenge. So the first thing is, if you are a mentor or a leader or a supervisor, when you go on to work on Monday, be intentional with what you do. Know that you are influencing people. And one of the first things that go out when it's a busy day is teaching and education. So, because it's not adding to productivity at the moment, but take a few minutes to have a learning conversation with someone. Be very aware that you are a teacher or guiding somewhere, and not just be productive, but take the time to help your colleagues. If you do that every day, it's like going to the gym. You don't see a result every day, but in a year, there is a difference. And so be intentional in being a leader, because good leaders don't create followers, they create good leaders. And the other thing is that if you have a mindset when you go to work, try to be confident, try to be competent, and be optimistic. If that's the way you step through the world and your colleagues see, this creates trust. And I think trust is the best glue in a team. So be competent, confident, and optimistic, because there's always a challenge. We won't hide from it. But I think building trust in your team is the most important thing.
I love it. Patrick, thank you so much for what you and your team are doing. And thank you for coming on the podcast.
Thanks so much for having me.